I'm David Houeto, as Group said. And let me share my presentation and start at once. Okay, so I wanted to put in practice what already Eric said and Didier said. So I wanted to show that it is possible to actually control malaria, but when we give power to communities. So what it is all about here actually is to see a kind of background and where did we implement this activity or project, and what was the intervention itself and the results and lessons we learned from this intervention. So the background, it's already known that malaria is a disease of poverty, you see, and there is a vital concern of child survival in Sub-Saharan Africa because there are a strong link between malaria and the socioeconomic, cultural, and environmental situation, you know. So actually, when we want to control malaria without considering all these factors we cause determinants, it cannot be possible. And then you can understand clearly why malaria is still a huge public health problem in this region, because the way they are now trying to control it is not the genuine one, you see. So actually, let's see where you can see malaria in the world, and mainly it is in Africa, with a huge burden in the economic and also the development situation of this region. Actually, it's not easy at all. I used to say that when we can put off malaria from Africa, Africa will then gain a lot in part of development issue. You see, so this is the mosquito we call Anopheles female. Anopheles, so who is very, very dangerous, in fact, for the kids, because in 48, 72 hours, it can cause the death of the kids with a severe anemia. You see how it is there on the picture. And where did we implement this project? It was in Benin, West Africa, in a village of 1,000 inhabitants. It's not far from Cotonou, the capital city of economic capital city of Benin. And there are people there with mainly they are in agriculture and traditional believers. So they believe that divinities can protect them, and then for them we'll see actually that fever is not a disease coming from a mosquito, but from witchcraft. And our intervention was for 27 months, from January 2005 to May 2007. We did it purposefully because we wanted to cover at least two big rainy seasons, so that we know, because that is the period at which we have a lot of cases of fever due to malaria, in fact. And the rationale of our intervention was based on WHO's approach, health promotion approach, that is to deal with participation, empowerment, contextualism. It is to take into account the context, the local context in what we are going to do, not to just come and put something in practice coming from elsewhere, no. And we want to gather stakeholders and use multi-strategy and deal with social inequity and try to anchor our intervention on the sustainability aspect. So we followed 8 stages for this intervention. The first one is identification and description of the health priority problem. The second, express problem. What is actually the problem coming from the perspective of the community, you see, not from our perspective as health professionals, no. And actually we, together with the community, we reformulate the problems and now do a prioritization, what they want to come first, and they want to start from what, not from our point of view, but from theirs, just to see what it is here. So here it is the stage 1. We did the baseline study to know what is the prevalence of malaria in this village. And then we come together with the community, we discuss the results we found, and now we analyze the situation of fever in this community to see actually what it is all about here for them with the result we got. And also we reformulate, you see the situation on the ground there, and actually we went to prioritization, and then it is for them to tell us where we should start from. Then they together tell us where to start from. And the second part of the stages were resources inventory. What are the resources available locally? Because before we come with the other resources or go for some other stakeholders, we do need to build on what they have locally, you see. So the other stage was the desirable and feasible changes. What do they want to change actually from their perspective? And then the implementation of the activities, and also in the end we assess what we did as activity. All this together with the community, in fact. So the inventory of the resources need to solve the problems identified in a truly global vision, and inventory of the various potential partners both within and outside the health system. So what we did with them. And the other one, identification of the different actions to be taken. They set up a committee, in fact. So this is the committee. That committee was to undertake all the activities identified by the community, but because the community cannot at the whole going to work together like this, it won't be efficient. So they decided to have a committee. This is the committee, in fact, in this village. And the other one is the implementation of the activities. Actually, the 7 activities were initiated by this community. The first one was, actually they agreed to go for early home treatment. And then together they tell us, okay, to do so, we do need actually to know how we go about it. Let us know how we give which tablets, which medication we are going to do, and how we put in practice what we have to do with our kids with that medication. So we, for that, we go to the Ministry of Health. They gave us some pictograms, and then we reinforced the capacity that way. And actually, the phase 8 was it was to evaluate, to assess what we did together. then, and the activities actually are, as I was saying already, it is early home treatment of the child malaria fever by mothers, the use of impregnated mosquito net, the parents' income improvement, setting up of a micro insurance for health, environment cleanliness, and creation of mosquito-free habitat, and systematic schooling of children and adult literacy. All these are activities, identified by the community itself. We were not part of it. They just went together, come back to us and say, okay, these are what we want to know. Because first of all, you need to know that for them, these are pictures showing what they ask us to come with as themes for capacity building for them to know. And all these, in fact, pictograms were put in inside the houses also to be looking at it and to be recalling what they have learned from us. So these are some sessions. And now, who are people that are going to help them to keep the tablets we together we bought? They went together. They for themselves, they identified criteria to designate these what we can call community volunteers. It is for them to know who can be community volunteers, well, with completely different criteria from what we used to with the health system in our country. So these are the three nominees who were the community volunteers in this community. And among the criteria, you can see that it has to be a woman and with kids, or had a kid, or all this. And the husband is not known as someone who can, be jealous and not accepting people to come and discuss with his wife, all this together. So now we have to train them to how to keep tablets at home and to distribute it to the community. And you can see, if you know Coatem, this is Coatem on the hand there. And then they also actually accepted to use the impregnated mosquito nets. In fact, actually, for short, let's say that for them, fever is not malaria. Fever is witchcraft, and you have to kill when witchcraft is around. So you cannot do anything to prevent or to cure it unless you deal with witchcraft people, and then you negotiate with them. And you'll see now that there is a household in this village with a genuine, let's say genuine locally house, and then he did not experience at all fever in his children. And they, in the community, they think that, oh, it is because he lies with witchcraft, and then they avoid to kill his children. And that was not the case, So actually, we went through a process with them that led them to recognize that actually mosquito is the cause. So then they accepted to use mosquito net. In the past, health professionals used to come and tell them through awareness program, use mosquitoes, and for them it is not possible to use mosquito net. You see, actually they accept to use it, and here they accept to put together money from their own, so that if there is a kid ill with a sickness, any sickness, they can they can let him go to the health facility and pay for that. So here are the initiative. They are trying to collect money, and together they write it down. It is their own initiative. And the other one, they want to improve the income income of the women mainly. So because women are the one taking care of, so they say that, okay, what we need is a cassava meals and the spice meals, and also a community feed even for women. You see, so how can we get money to do all this? We put our idea together, and we found that it is possible to get some means and to put this in practice for them. The fifth activity was adoption of a new housing model and an environmental sanitation. Let me show you. You see, this is the only one in 1,000 inhabitants. This is the only one house you can see that way in that village. The others are not like that. And this guy here do not experiment any favor in his children and no death. And they say that all the village were against him because no death in his household. And it is because of this, when we realize this, because by discussing with them, they say there is only one guy in the village, he liaised with witchcraft people, and then they avoid him. So, and okay, we said, okay, let's see this guy. Well, when we went there, we can see that, oh, it is different, actually. And the guy explained to us that everything is like that, but he did nothing with witchcraft people, so it's not a problem. He thinks that it is, as her professional used to say, it is a mosquito who is behind all this fever and children death in our village. So because of that, in the end, they accepted now to us to come with an architect. So this guy in the middle there is an architect. He came and they say, okay, this kind of house we want actually is the one from this guy. So he went there, he looked at it, and then he drew the plan and came back to let them validate this plan. That's what he was doing there, you see. And then as the result, to put it short, we can see actually that at the community level, we have community participation increased at 80%, and development of skills in the proper management of fever with through medication, community health volunteers, or mutual health insurance, impregnated mosquito net use, new type of housing, you see, and ability to analyze fever issues in this village. Also, the development of self-esteem, critical awareness, and community capital, free communication and expression of views of people, because people can come now, discuss and say everything. And actually, we exchange our point of view with them. We told them what we heard from other parts of the world about fever, and all this helped actually to come with another point of view and another perspective on fever issue. Community pressure for appropriate use of care in case of child fever, because actually this committee they formed, the committee actually trained other people in the village, so that even if the kid is not your kid and you can see that he has fever, then you go straight to the community volunteer and you get a tablet for this kid, because it is a village. When the father came back home, he has to pay because it is compulsory, you see. And solving other community problems related, what we call social empowerment. Actually, when we finished this program, they called me back and said that, come to see. We realize now a drinking water fountain for ourselves because we know actually how to go to Abomey-Calavi, the capital of the district, and to see people and to discuss, to negotiate with them because you showed us how to do this. And then they get water, drinking potable water in the village afterwards. So let's see with this graph that the recourse to adequate healthcare before and after intervention increased. As you can see here, it is before, at least we have 11%, and here we have 74% after the intervention. And the other one here, it is the representations of the type of fever in children. Actually, before the intervention, only 44% can think that, oh, it can be malaria. But after the intervention, 100% think that the first thing in our region should be malaria. So you go to the health volunteer, and actually it is changed because you do the the rapid test, and then you get the medication if it is positive. And witchcraft, it was about 17%, but after the intervention, it is 0%. And the adequate treatment of fever in children, it was 25% before, and now 83% after the intervention. And the use of infusion, lemon juice, no treatment was about 31%, but after the intervention, only 10% continue using this kind of treatment. And malaria active screen, when we did it, after before we start the intervention, we had 24% of positive malaria tests, and after this we have 14% that are positive actually. And then for lesson learned, in fact, what we did was that we can see that people, and if I can tell you, in fact, up to today, they still calling me. I was the principal investigator, and they will keep calling me actually to be part of the village, to come and discuss with them for any other people. So that is what we can call sustainability, you see. And actually, when there is marriage or a death, they call me, yeah, we are now in this situation, come and be with us, and this kind of situation. Because we think actually that it is because the priority issue for the community was really fever in children. And when we were dealing with that, it was something they agreed with, you know, and community, the willingness and the leadership they got that time helped also to do all this. And we can see that they got critical consciousness and community. We did everything based on their assets also. And the intervention was under the community control because all we did came from them. They proposed everything we have to do. Nothing came from us, in fact, at that. And we were there like advisors. You know, we support the communities by as an accompanist through the social cohesion development, mutual support, so that they can be together. You can see that at that time there were conflicts in the village because the village had 3 hamlets, and there were some conflicts. We were there to solve these kind of situations, to let them be together, to work together, and that was happened really. And we also make link with other stakeholders. We went to the capital city of the municipality with them, meet with this and that, so they know how to go actually to see people in the civil servant part of the society. And also the role, our role as researcher or intervener was to develop the community skills, through capacity building, but choosing only teams coming from them, not we come and say, okay, we want to teach you this and that. No, they, by doing the activity, by undertaking the activities, they came up with some difficulties and tell us we need to know this, we need to know that, help us to know this, and then how we develop some item or teams to teach and to discuss with them. And we help them develop the self-esteem, because there are some people who are there saying that no, we can't, malaria is not something we can cure here, it is witchcraft. And we let them to come together to see, to hear from other people, other members from the community, how they are discussing the issue. So we were there to put them together and to value the positive practices. We always say, when it is something good, that is wonderful, and then you continue, and then we can publicly say it, so that people will be, gorgeous and say that, okay, we proud for doing good things. We give them, incitement and let's say encouragement to the initiative, the end. To conclude, to say that, in fact, for this population, malaria do not exist. The word malaria is even doesn't exist, you see, and it is fever, and they know witchcraft. But by going, discussing with them, and together we came to solve the issue, actually. And they came up with some genuine intervention activities, like because we were in that kind of illiteracy, and we couldn't know that fever is malaria. So our children have to go compulsory to school. We see this kind of situation. So actually, in that village, every kid has to go to school in that given village up to date. That is what I just want to share with you. And if you can ask me some questions, I can explain deeply. Because of time, I put it short like that, but I can explain to you. And there is also a publication I sent to Sylvia also. She can share it for you, with you. And also, there is a book on this experience. In fact, I can also share it with you. That is it, and I thank you, and waiting for your question. Thank you.